Neurology, a knowledge feast for all neurologists. Today is episode 52nd, and we have a very interesting case presentation from Savita Medical College, Chennai. Today's topic is catatonia v psychiatry. Friends, this has been possible because of untiring effort of our course directors, Professor Dr. Sudhir Shah and Professor Dr. Lakshmi Narasimhan. And I would also like to have a very warm welcome to faculty, teaching staffs, and the senior residents of Savita Medical School who will be present case today. As we know, this knowledge feast continues for little more than an hour, and we intend to close it by 9:15. An honor and privilege to say a few words about our program director, who needs no introduction, Professor Dr. Sudhir Shah sir. He is Professor and HOD, we all know, at prestigious Srimati NHL MMC SBP SR Ahmedabad. And sir is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Many awards and accolades to his credit. The recent one has been on June 5th, 2024, where he was awarded as a French Senate, Paltas du Luxembourg, Paris, France, which is the highest international award for Indians. Sir is also conferred with most prestigious award, Padam Shri, because of his work to society, people at large, and his research work, and is also recipient of PC Roy Award. Professor Sudhir Shah sir's interest is into stroke, neurodegenerative disease, and epilepsy. Our second program director, we all know him very well, Professor Dr. Lakshmi Narasimhan.
Network unstable.
Hear me? Hello. Sir is also recipient of Paltus Advisor A.B. Baker's Award, Best Paper Award, and he has been a 3-term executive member in Indian Academy of Neurology. He has been a CME convener, and his contribution to academic world in the field of neurology is immense. I request both our program directors to take it forward from here. Thank you.
Hello.
Yes, sir.
Audible, may I have the
sir.
first slide, please? Yeah. Thank you, Thank you, Dr. Manoj Kumar, and welcome you all to this wonderful feast for all neurologists, Secrets of Neurology. It's the 52nd continuous consecutive episode, which is taking place every month on the last Friday. So, friends, it is due to the exceptional interest shown by all of you that we are able to continue this most, I would say, sought after and I think one of the most longest running series of webinars ever since the COVID time. So I appreciate your zeal and interest to all delegates, as well as I personally want to thank all the faculty of all different medical colleges and institutions, as well as these medical students, specifically the DMD students who are presenting their cases, followed by assistant professors and associate professors taking the localization and differential diagnosis and discussion, and final expert comments by the professors and the head of department. So this is a wonderful design, and I'm thankful to my colleague, Professor Lakshmi Narasimhan, whose untiring efforts have made this extremely palatable and likable. And I must also thank INTAS, Closed Cell Division, led by Mr. Chadda, Dr. Manoj, and the team for the logistic support and the networking that you are doing, including Dr. Shweta. So, friends, without taking much time, I want to introduce you to the team, today's team of Secrets of Neurology. And today, the institute is Savitha College from Chennai. And today the case presentation would be by Dr. Monica Reddy, who is a DM resident, second year neurology, and she did her DNB General Medicine in 2018 from Yashoda Super Specialty Hospital, Hyderabad, and now doing DM Neurology, second year at the Savitha Medical College. Next slide, please. Next slide, please. The case is about catatonia beyond psychiatry. So it's a little catchy title. I'm sure all of us, we are going to have some surprises in the case. So Dr. Satish Kumar would do localization for us and also discussion. He's an assistant professor from the same department and is a DM neurology from Stanley Medical College, Tamil Nadu. MGR University. He had awards and accolades like Association of India PG Teaching Program Gold Medal winner, 10-con Base Platform Presentation 2018, and talk on emergencies in neurology at Pondicherry and neuroinfection in 10-con in 2021, and Korea and Epicon, etc. The member of Association of Physicians of India, Indian Academy of Neurology, and Indian Stroke Association. He has published approximately 15 articles and case reports so far, and he has contributed chapters in 10. This Tamil Nadu Association of Neurology, of course, also in IAN. He's an associate editor of IAN ICP, 100 Questions in Neurology, and so on, and one of the co-authors of Handbook of Neurological Drugs. Next slide, please. Dr. M. Nirumal Kumar is an assistant professor. He will take further discussion of the case specifically to etiology and other differential diagnosis. And he is also DM neurology. He's from Madras Medical College, recently passed 2024. And he was, he has published some papers like admission, leukocytosis and implication intracerebral hemorrhage, and that was an international advance in medicine. Case report on disulfiram reaction causing cortical blindness, LG encephalitis, presenting as focal cortical encephalitis, etc. He had achieved third place in SRM quiz, Apollo Senior Medical Quiz, and National in TISA. I know I was one of his examiners. He had achieved a national level Young Scholar Award. He second place in hematology quiz and first place in Wonka quiz, etc. And is the principal creator of DM neurology APP NEET for NEET. His areas of interest are neuroimmunology, epilepsy, and neuroophthalmology. Next slide, please. Dr. Vasudevan, D. Vasudevan was supposed to be here. I wish he can join, but I think he's taking his flight, and instead he's a personal friend, and we both are running together contemplative neurology subsection of IN. He's also editor and author of Practice Pulse in Neurology Series 1, 2, 3, and Management Pulse in Neurology, and senior editor and author of IN Textbook of Neurology, etc., etc. And founder of Beyond Brain Colloquia and convener of the Contemplative Neurology subsection of IN. Instead of him, I think Dr. Vinod Kanan is going to give final comments of the case, that is catatonia beyond psychiatry. And once again, I'm here to thank all the delegates, all the faculties for 52 episodes. so far 51 episodes, and for today's faculties also, and of course, team Globusel and my colleague Dr. Lakshmi Narasimhan. I don't know whether Dr. Lakshmi is he here now.
Sir, he is
Yes,
here.
Fine.
yes, sir. Yes, sir.
Okay.
Yes, sir.
Yeah, Dr.
Sir,
Lakshmi, welcome,
sir,
welcome, dear.
my hearty thanks to Professor Vasudevan and his team, Vinod Khanna, Satish and Nirmal and Monica Reddy for accepting our request, sir. My sincere thanks to them. We are looking forward for the excellent educational fees. Thank you.
Yes. Most welcome and thank you. Now, Dr. Kanan, the mic is all yours, and please proceed with the case.
Dr. Vinod,
Dr. Vinod, please unmute yourself. Dr. Kanan, please unmute your mic, please.
Can
you start the case?
Dr. Monica, can you give a call to Dr. Vinod?
Yes, sure.
Please unmute yourself, Dr. Vinod.
Yeah, he has unmuted.
On behalf of Neurology Department, Savita Medical College, thank Professor Ellen sir and Sudhir Shah sir for giving us this opportunity. Let's proceed with the case.
Please, thank you.
Dr. Monica, can you share your slide?
Yeah, sure, sir. Before starting the slide, I would like to thank my HOD, Dr. Vasudevan sir, Dr. Vinod Khanna sir, Dr. Lakshmi Narasimhan sir, Dr. Sudhir Shah sir, and my faculty for giving me this opportunity. So here is the case. So there's a patient, Mr. X, age 20 years, gender male, occupation, he's a student. He's hailing from Sholinganallur. Informant is mother, and the information is reliable. Handedness, he's a right-handed individual.
Dr.
So
Monica,
the
your slide, please.
Sorry, sir.
Your slide, please.
Slide
Dr.
is
Monica,
slide,
your
please.
slide.
Slide is not there.
Oh, 1 second. Is it visible, sir?
Yeah.
Yeah.
And
You can start now.
Okay, so the patient, Mr. X, age 20 years, gender male, occupation, he's a student. He's hailing from Sholinganallur. Informant mother, and the information is reliable. Handedness is a right-handed individual. So the pre-morbid behavior, patient is a student by occupation. He daily wakes up by 7 a.m. in the morning, have his breakfast by 8 a.m. and leave to college. After returning from college by 5 p.m., he would go for a casual walk with his friends or play cricket and return home, and will have his dinner by 9 p.m. After finishing his daily course, he would go to bed by 10 p.m. The chief complaints: patient presented with new onset seizures, multiple episodes since 25 days. Behavioral disturbances and memory disturbance since 15 days. Sleep disturbance since 10 days. History of presenting illness. Patient, a right-handed individual who was apparently normal 25 days back, then developed one episode of focal seizure during daytime on July 28, 2024, starting from right upper and lower limb, initially with numbness starting from the right lower limb and ascended to right upper limb with involuntary jerky movements lasting for 5 minutes. And the patient was aware of the episode. Patient was then admitted at Chettinad Hospital and treated with medications and got discharged the next day. But then patient discontinued medications after discharge. After 5 days, patient again developed one more similar episode of focal seizure during daytime on August 2nd, 2024, lasting for less than 5 minutes. Patient was then admitted back to Chettinad Hospital. MRI plain brain was done, which was normal. EEG was done, which was normal. And then he got discharged in 2 days with medication advice. Repeatedly, after that also, patient was not on medications for 10 days. He was completely normal for 10 days and he went back to college as well. On August 12, 2024, he had developed multiple episodes of focal seizures with no loss of consciousness, for which he was being taken to Royapeta Hospital and got discharged after 1 day. Then he had total insomnia for 10 days. Patient usually goes to sleep at around 10 p.m. and sleeps within half an hour and wakes up at around 7 a.m. in the morning. But gradually he could sleep only half an hour to 1 hour and could not sleep after that. No parasomnias were associated with the sleep. Patient had loss of interest in daily activities that he used to do early, like playing cricket with friends and watching television. Mother acknowledged prominent slowing of his activities. Patient then developed well-formed visual hallucinations during the day. Mother noticed that patient was preoccupied most of the day and found muttering to himself and sometimes loudly answer as if he was being asked a question. When asked about whom he was talking to, he says he was seeing a lady sitting in the corner of the room speaking to him and asking him to commit suicide. Then it progressed to excessive fearfulness. Following this, patient had memory disturbance in the form of repeatedly asking for food despite eating, searching for objects. So here the visual memory is impaired. Later, patient was being taken to a temple where some rituals were performed on him. Following this, patient had severe anger outbursts associated with behavioral disturbance. Upon admission to our hospital, patient was not speaking, but he was able to comprehend what was told to him and he communicated via gestures. Meanwhile, patient was taking care of his activities like brushing, bathing, but very slowly. Then he finally progressed to complete mute state. There is no wandering behavior, no history of getting lost, no history of trauma associated, no history of fever, no history of headache, no history of weight loss, no history of echolalia, no history of echopraxia. No history of diplopia, no history of nasal regurgitation or choking. He was able to chew, munch, and swallow food without difficulty. There is no history suggestive of hearing loss or dizziness. Patient was initially admitted in psychiatry ward in view of acute behavioral change. Then he got shifted to neurology ward for further evaluation and treatment. Past history was not significant. There was no previous history of psychiatric illness. Family history is not significant. There is no native drug intake. So, personal history, he is a non-vegetarian. Sleep is as described above. He is not a non-alcoholic or smoker. Bowel and bladder are normal. Summary, he's a 20-year-old male born out of non-consanguineous marriage. He presented with new onset focal seizures, multiple episodes. Patient then had well-formed visual hallucinations and then behavioral disturbances in the form of agitation, anger outbursts, memory disturbances, and decreased interest in daily activities, along with decreased speech output, which eventually progressed to mute state, slowness of activities. There's no history suggestive of cranial nerve, motor, sensory, extrapyramidal, and cerebellar disturbances. General examination. Patient is a moderately built individual. He was afebrile on examination. Blood pressure was 110 by 90 mm of Hg. Pulse rate is 82 per minute. Respiratory rate was 18 per minute. There was no pallor, icterus, clubbing, cyanosis, and lymphadenopathy associated. Higher mental functions. Patient was conscious, but the patient is mute. He doesn't respond when talked to. Attention could not be tested because... Hello. Hello. Am I audible? Hello.
Yeah,
You're audible. Dr. Vinod, kindly mute yourself. There's a disturbance. Dr. Vinod,
Yes.
No,
please mute.
MMSC
Can
could
you
not be
mute
performed.
please, sir?
MMSC could not be performed as the patient was mute. Lobar
Vinod,
function
can you
could not be-
please?
And the cranial nerve. First cranial nerve could
Just
not
a
be...
minute. Just a minute.
Sure, sure. Sir.
Doctor, just a minute. Sport team, can you mute Sudhir, sir? Yeah, now you can.
Okay, sir. The first cranial nerve, olfactory nerve, could not be tested. The second cranial nerve, optic nerve, visual acuity was grossly normal. It was like great, more than 3/60, both on the right and the left side. Color vision could not be tested. Field of vision could not be tested. Pupil size was 3 mm bilaterally. Pupillary light reaction was normal. Fundus, there was no papilledema associated in both right and left eye. So, oculomotor, trochlear and abducens nerve, there is no abnormality associated. Extraocular movements were full. Saccades could not be tested. Pursuit could not be tested. And when it comes to trigeminal nerve, corneal reflex was present both the sides. He just winces to pain. Facial nerve, there is no gross asymmetry of the face on both the sides. Eighth cranial nerve could not be tested. Glossopharyngeal nerve and the vagus could not be tested. Spinal accessory nerve could not be tested. Hypoglossal nerve also could not be tested. Bulk, right side of the arm, it was 21 centimeter. Left side is 20 centimeters. Forearm, it was 18 centimeters, and left side, it was 18 centimeters. Thigh, it was 34 centimeters on the right side and 34 centimeters on the left side. Leg, it was 25 centimeters on the right side and 25 centimeters on the left side. Tone was like upper limb, lower limb, bilateral, both right and left side. Waxy flexibility was present. And the lorazepam challenge test was negative at that time. So formal power examination could not be done, but the patient was moving all the four limbs. Superficial reflexes, corneal reflex bilaterally it was present, conjunctival reflex bilaterally present, abdominal reflex present, bilateral plantar reflexes flexor. Deep tendon reflexes, jaw jerk is absent, trapezius is absent, biceps, triceps, supinator, knee jerk are one place, both the sides. Ankle reflexes present. Primitive reflexes, glabellar tap, rooting, grasping is absent. And this is the catatonia. Sensory system examination, Rombox could not perform, joint proprioception couldn't perform, touch pain, he just winces to pain, timed vibration, we couldn't perform. Cerebellar examination, no spontaneous nystagmus, head titubation, no head titubation, no stance ataxia, no truncal ataxia. Extrapyramidal system, patient had catatonia, perioral dyskinesia is present, no other abnormal movements. These are the orofacial dyskinetic movements seen. Signs of meningeal irritation were not there. Skull and spine were normal. Autonomic nervous system, there was no resting tachycardia, orthostatic hypotension, there is no drop of blood pressure on sitting, standing blood pressure could not be examined, no sweating abnormalities, sustained hand grip, cold water immersion test couldn't perform. Cardiovascular system examination, S1, S2 are heard, no murmur was associated. Respiratory system examination, normal vesicular breath sounds, no added sounds. Abdominal examination, no organomegaly, bowel sounds were heard normally. So the final summary is like 20-year-old male born out of non-consanguineous marriage who presented with new onset focal seizures, multiple episodes. Patient had well-formed visual hallucinations and then behavioral disturbances in the form of decreased interest in daily activities along with decreased speech output, which eventually progressed to mute state with slowness of activities. No history was suggestive of cranial nerve, motor, sensory, extrapyramidal, cerebellar disturbances. But on examination, patient had severe catatonia, perioral dyskinesias. Rest of the examination was limited because of his catatonic state. Sensory system, cerebellum and cranial nerves were grossly normal. Hello, sir. Hello.
Yes.
Yeah, so this is a summary of the case. So,
You're audible to us.
yeah, ma'am. So as the patient presented with a new onset acute behavioral change associated with seizures, the differentials would be like autoimmune encephalitis and the infections. As the patient was not associated with any prior psychiatric illness or any native drug intake or any comorbid associated with him. So we thought of like autoimmune encephalitis would be the first and foremost diagnosis for this patient. And I would like to ask my assistant professor will be taking over this after this.
Yeah, Dr. Satish will take.
Yes, I am handing it over to Dr. Nirmal, sir.
Okay.
Dr. Satish sir would be taking over.
Okay. Any,
Can I
you
start?
unshare your slide.
Yes, sir. Yes.
Madam, you unshare your slide.
Sure, sir.
Dr. Nirmal, can you share your
So
slide?
I will start.
Okay. Thank you.
Yes, sir. Sir, am I audible, sir?
Yes.
Are my slides
Yes,
are visible,
yes,
sir?
Yes, sir. You are audible, sir.
Yes, sir. Sir, at the outset, I would like to thank Professor Vasudevan, sir, and Professor Vinod, sir, and my colleague Nirmal Kumar, and also pillars of this forum, Professor Ellen, sir, and Professor Sudhir Shah, sir, for running the Secrets of Neurology for the past few years successfully. And after my PG ended there, I would like to analyze the symptoms and localize, sir. That is my objective now. So I would like to thank everyone participating in this meeting. And initially, the patient had a seizure, sir. That is the first complaint of the patient. Seizures are generally, they are cortical in origin. Subcortical seizures are possible, but seizures generally cortical in origin. When you analyze the semiology, it will help in lateralization and localization. So here, it started as numbness involving the right lower limb, then it followed the upper limb, and then few jerks, preserved awareness. So here, we will classify according to the ILA semiology. We use the term focal seizure with awareness. It's a non-motor in onset. So probably a sensory motor cortex involving the left hemisphere. So that will be the localization for the seizure. So after seizure, the boy developed insomnia. So insomnia is definitely a central feature where it involves the sleep promoting region and wake region. There is an imbalance between these regions where there is a hyper arousal system is active, the sleep promoting systems are inhibited. So that is the mechanism behind insomnia. So we can localize only to the sleep circuit where lateral hypothalamus is responsible for maintaining wakefulness, and VLPO, that is the ventrolateral preoptic area of hypothalamus, is responsible for sleep. So sleep area is inhibited, lateral hypothalamus orexin region is activated. So that would be the localizing feature for insomnia. So we can just localize to sleep circuitry. And next, he started to have loss of interest in daily activities. So that comes under apathy. So when you lose interest, when you don't show any emotion to anything, so it is defined as apathy. So when apathy is there, so we have a confusion whether it could be a depression or it's simply an apathy. So apathy and depression are certainly two different entities. So depression can have symptom of apathy. So depression will also have hopelessness, feeling guilt. All these things were not there. It was just simple apathy where he don't do any activities. So for apathy, we classically locate in the medial frontal cortex, that is particularly involving the anterior cingulate cortex and the basal ganglia, that is particularly the caudate and putamen. So that is a classic area for localizing loss of interest or apathy. Akinetic mutism and apathy are a spectrum of motivational disorder. So in between, we use the term abulia. So the mildest form is apathy, the extreme form is akinetic mutism, which the boy eventually developed as the illness progressed. The next, regarding the slowness of activities, the mother has noticed he was very slow. See, that need not necessarily be a bradykinesia, or it need not necessarily involve Parkinson features, because apathy itself is enough to cause slowness. So again, it will come to the striatal pathway, striatal and anterior cingulate cortex pathway. So slowness can be due to apathy itself, because he didn't have any other Parkinson features like rest tremor or rigidity, but he had a type of hypertonia in the form of waxy flexibility. So I would consider it apathy itself is enough to explain the slowness of activities. Next is the visual and auditory hallucination also, because someone has informed him to die. So some female voice is telling him to die. So both he had a visual and auditory hallucination. The visual hallucination, he had a well-formed images, human images he has seen. So well-formed hallucinations generally we localize to a temporal lobe. Auditory hallucination, again, it goes to the auditory cortex and also the association area. So multimodal cortex or association cortex are more responsible for causing such type of hallucinations. So again, it localized to temporal lobe. Next will be the paper circuit regarding the memory impairment. So he used to eat food and forgets the food, and he used to search for objects. So both visual and memory, episodic memory is impaired. So though we classically localize to paper circuit, the medial temporal lobe, particularly the hippocampal region and the parahippocampal region, form the core system. So it could be either the temporal lobe involvement, because as hallucinations also come from the same region. So I would like to localize to the temporal lobe, or it could be paper circuit anywhere, even including the anterior cingulate cortex, which is also a part of the paper circuit. So first localization should be a paper circuit, and also I would also co-localize along with the temporal lobes, where it forms the major core of the memory, the medial temporal lobe, particularly the hippocampus and the parahippocampus. And next, after going to a temple where some rituals were performed, he started to develop anger outburst. So regarding the anger outburst, it is a disinhibited behavior where we have the fronto-subcortical circuit involving the orbitofrontal cortex, which is one of the prefrontal cortex, where the social behavior, everything is governed there. So any irritability, any anger outburst, any disinhibited behavior, everything comes under the orbitofrontal circuit disruption. So probably here a fronto-subcortical disruption involving the orbitofrontal cortex. So that will be the localization here. As I said earlier, apathy has progressed to akinetic mutism. At the end of the day, he didn't do any ADL. He just became mute and quiet. So that means the disease has progressed and it has reached to the level of akinetic mutism. Again, the same area involving the frontal cortical subcortical circuit, involving the anterior cingulate gyrus and the striatum. Next, he had, as Monica showed in a video, there was waxy flexibility. It's a form of a paratonia where it's similar to bending a warm candle. So the patient will maintain the posture what the examiner has kept, and mutism. So all these features point to catatonia. So catatonia is a disorder of both motor and as well as the mood, affect and thought and cognition. So here he has a classic symptoms of mutism, waxy flexibility, and stupor, and even stereotypy. And all these symptoms are categorized under the entity called catatonia. So when you localize catatonia, so catatonia is not a single area to localize. So it's again a circuit involving the basal ganglia and the prefrontal cortex. And regarding the posture, parietal lobe is implicated in waxy flexibility. So when the patient maintains some abnormal postures or postures kept by the examiner, parietal cortex is implicated. Connections to the parietal cortex, not entirely the parietal cortex. So here, if you look at the neural circuit of the catatonia, you can see predominantly the motor cortex, orbitofrontal cortex, and DLPFC. Everything is involved here within the loop involving the basal ganglia and the prefrontal cortex. So this is the neural circuitry involving the catatonia. So this circuitry is definitely involved in this patient, as the patient had a classic core features of catatonia. So to summarize my structures of involved, so for the first symptom seizure, left sensory motor cortex is involved. For insomnia, you can include the sleep circuit involving the hypothalamus. And for apathy and mutism, again, the anterior cingulate gyrus and its connection with the striatum. And slowness can be due to apathy or basal ganglia. We can keep it either way. And regarding the visual and auditory hallucination, it will be the temporal lobe and the association areas. And regarding the episodic memory loss, including the visual memory, so I would invoke both temporal lobes, as right-sided temporal lobe is more for the visual memory. So both temporal lobes may be involved or along with the paper circuit. And regarding the anger outburst, again, this is a orbitofrontal cortex circuitry damage. And regarding the catatonia, it's a neural circuit comprising all the parietal cortex, DLPFC, OFC, motor cortex, and the striatum. So its entire circuit is responsible for producing the various features of catatonia. And I just forgot to add it, sorry, the perioral movements which was shown in the video, the perioral movements are due to the dopaminergic excess in the indirect pathway. So they have a excess movement was noted in the perioral region because of the dopaminergic excess in the D2 pathway, indirect pathway. So that would be the localization feature for the perioral dyskinesia, which we commonly see in various autoimmune encephalitis, like some encephalitis disorders. So with this, my localization is over, and I would like to ask Nirmal Kumar to take over from here. Thank you.
Sir, you unshare your slides.
Yes, sir.
Dr. Nirmal, can you share your slides?
At this point of time, my hearty appreciations to Satish. A wonderful disposition of clinical dissection of the clinical semiology and its localization. I'm sure the PGs would have enjoyed it, and this is exactly the way in which the postgraduates should approach the localization. You have really set the trend, Satish.
Sir,
My hearty appreciations to you.
Thank you, sir. Thank you, sir.
Can you unmute yourself, Nirmal? Dr. Nirmal? Unmute yourself, sir. Sir, we are not able to hear you. Can you unmute yourself?
Yes, sir. Is it audible now, sir?
And can you go for the full screen?
Yeah. So,
Thank you.
Thank my team at Savita, my HOD, Professor Vasudevan sir, and Professor Vinod Kannan sir, and my mentor and teacher, Professor Lakshmi Narasimhan sir, for the opportunity, and also Sir Dr. Sudhir Shah sir for having me over. So, from the previous discussion, we have structures involved are, as Satish sir beautifully discussed, left somatosensory cortex is involved, which eventually split to the motor cortex, which are responsible for the seizures. Behavioral disturbance, as localized by Satish sir, orbitofrontal cortex and its connections. Apathy, medial prefrontal cortex. Formed visual hallucinations, the temporal lobe, or can be brainstem also. Memory disturbances, medial temporal lobe. Patient had both visual memory disturbance and verbal memory disturbance, so both right and left medial temporal lobes. And finally, mute state, waxy flexibility, which is probably catatonia. So the thing with this patient is that he somehow ended in psychiatry ward because of his nature of illness. Because he had a short history which originated the seizures, and unfortunately for the patient, he was conscious during the seizure episode. So when this is a history of seizure and the patient says he is conscious during the seizure episode, we tend to call it pseudo seizure. And his later symptoms were predominantly psychiatric. So he had behavioral disturbances and finally turned into apathy. So his clinical diagnosis, which are called into, was catatonia. So had he not had a seizure, he would have likely been managed with a psychiatrist alone. He wouldn't have come to neurologist at all. So I just wanted to, we as a team wanted to shine a light on this syndrome called catatonia and how it evolved through the years. So what is catatonia? So initially, catalepsy was described as disturbance of brain and nerves in 1784. It nearly took 300 years. Only in 2013 that catatonia was recognized as an independent entity. All through the years, it was considered a part of psychiatric prodrome, and few called it dementia precox, and few called it a part of schizophrenia itself. So it took about 300 years for it to be recognized as a separate entity. So this is a book on catatonia called as Fears, Magic of Fears. So which was penned by Edward Shorter. So again, this was also described in terms of a psychiatric illness. Catatonia was never considered a part of organic illness. So what is catatonia? Catatonia is a psychomotor syndrome with hyper, or parakinetic movements, which often presents associated with mental illness or medical other neurological conditions. So as per DSM-5, we require 3 of these 12 criteria, which is catalepsy, waxy flexibility, stupor, agitation, which is not induced by external stimuli, mutism, which the patient had, negativism, which means that patient won't even comprehend what we are saying or not respond to what we are saying, external or internal stimuli, which also the patient had, posturing, mannerisms, stereotypy, again, the patient had that, grimacing, echolalia, and echopraxia. If you see how frequent the symptoms are, immobility is the most frequent symptom, mutism also is the most frequent symptom. Now coming to DSM-5, it classifies catatonia into 4 syndromes: catatonia associated with medical conditions, schizophrenic catatonia, catatonia with affective disorders are not otherwise specified. So DSM-5 is classified a separate entity called as catatonia with medical conditions apart from those associated with psychiatric disorders. So put in simple words, what is catatonia? It is an excessive fear. So patient feels excessive fear. In earlier days, it was described in animals. When it encountered an excessive fear, it suddenly becomes mute and catatonic. So that is. So in olden days, it was described as animal when put into excessive fear becomes catatonic. That is what it is described. So similarly in humans also, excessive fear and they become immobilized. That is catatonia. So how does it happen? As Satish sir beautifully described this slide, I just want to put more light on the slide. So these are the circuits involved in catatonia. Basically, in a phase of excessive fear, there is overactivation of the orbitofrontal cortex. So when orbitofrontal cortex is overexcited, it has to communicate to the motor circuits, right? So it has to communicate to the parietal cortex, it has to communicate to the premotor cortex, and it has to communicate to the medial frontal cortex. So medial frontal cortex is via the GABA receptors, premotor is via the dopaminergic receptors, and the parietal cortex is via the glutamate receptors. So the three circuits involved in catatonia are dopaminergic circuits, glutaminergic circuits, and GABAergic circuits. And there is glutaminergic excess, dopa depletion, and GABA depletion. And this is precisely why lorazepam helps in catatonia, and also dopamine agonist also helps in catatonia. And neuroleptic malignant syndrome, which is a severe form of catatonia, is precipitated by dopamine blockers. So it is of three types: hypoactive type, hyperactive type, and a malignant catatonic syndrome, which is a spectrum of neuroleptic malignant syndrome. So what is this lorazepam challenge test in catatonia? So when a patient has come to apathy and is not mobile, we want to know if it's catatonia or not. So this was classically described in catatonic patients. When we give a lorazepam challenge, that is, we give about 1 mg over 5 minutes, then we gradually increase the dose up to 4 mg. Usually we expect the patient to respond by at least 50% within the next 4 to 6 hours. That is positive lorazepam challenge test. And if lorazepam challenge test fails, we have to go for something called as electroconvulsive therapy. So we have a short video of the patient who responded to lorazepam beautifully. This is not the patient in question, this is a different patient. So now he's not obeying. This is a video of him having a catatonic state. And he was given lorazepam. And this is, and this in this patient, the response was almost instantaneous. He responded within 5 minutes. We gave 4 mg lorazepam, he responded within 5 minutes. And this is a lorazepam positive test. But the patient in question had a lorazepam negative test. So we went back to literature to look why few patients respond to lorazepam and few don't. It said that low response to benzodiazepines suggests a variable mechanism of catatonia in anti-NMDA encephalitis. We all know that NMDA encephalitis is a glutaminergic receptor. So in anti-NMDA encephalitis, the glutaminergic receptors are internalized. So this excess extracellular glutamate, and that contributes to pathogenesis of catatonia in such patients. So the GABA A and dopamine is not so much involved in patients with NMDA encephalitis. So coming to etiologies, it has a broad range of DDs. So we looked at these things, infections, because he had acute presentation, we looked at infections. Immunological, mainly the NMDA encephalitis, because it contributes to about 72% of all catatonias. Metabolic syndromes, of course, he didn't have any metabolic abnormalities. We also looked at that. And medication withdrawal, this is very common. Patients who have benzodiazepine withdrawal or dopa withdrawal also can develop catatonia. So coming back to our patient, the initial MRI and EEG were normal. So all his symptoms were put into a psychiatric bracket because seizures were presumed to be pseudo seizures, and the symptom of behavioral disturbance, catatonia, were all considered psychiatric. It was put into psychiatric bracket, and his lorazepam challenge test was negative. This was his initial MRI, which was normal, and his repeat MRI showed a left medial temporal hyperintensity here, and there was no diffusion restriction. So this made us look into organic causes of catatonia. And we did a CSF analysis. Cells were 3, protein sugars were normal, HSV1, 2 were negative, and there is no response to acyclovir.
Yeah, Nirmal, can you show the first MRI, please, again?
All this, the patient had done MRI outside. So this all the sections we had, sir. It was normal, sir. He had only the contrast images, sir. So he didn't have the rest of the images.
Okay, no problem. Go ahead.
So his repeat MRI showed a subtle T2 flare hyperintensity in the left temporal lobe, but there was no diffusion restriction. CSF was normal and the HSV1, 2 PCR were negative, and there was no response to acyclovir. So, and as most of us know, the NMDR was turned out positive. He only improved partially with steroids. When given IVIG, he was given IVIG, but in view of catatonia, they gave maintenance therapy to him. So rituximab was started on him. And this is his latest video taken like 1 week back.
Study பண்றாங்க ஒரு வாட்டி நடக்கும் சரி திருப்பி வாங்க
Sir, thank you.
Yes. Dr. Vinod Khanna speaking. Thank you, Nirmal, Satish, and Monica for presenting the case. We have presented this case mainly for its uniqueness. Although behavioral symptoms, psychiatric symptoms, delusions, hallucinations, speech disturbances, sleep disturbances commonly come across in all the autoimmune encephalitis. Catatonia is one of the rare manifestations in NMDAR encephalitis. That is the idea of presenting this case. And the PG should know about this. As the patient has been landed in psychiatry, when we saw the patient, catatonia was the presentation. So based upon the history as well as the investigations, we come to a conclusion that it comes under autoimmune encephalitis, NMDAR encephalitis, and we have presented this case. And one other unique feature is the Lorentz-Form challenge test, which Nirmal has demonstrated. There is one of the classical features in catatonia, which you can try in a patient with catatonia to document that. So thank you so much for allowing us to present this case.
Dr. Kannan, you have any more comments? Yeah. I must appreciate and congratulate the whole team for bringing out this wonderful case. And specifically, I think during this last 52 episode series, this is probably the first case to discuss catatonia as the main symptom and highlight the whole different gamut of syndrome and etiology of catatonia. So congratulations and wonderful. Now, there are certain questions in question answer box. You have seen what is the vaccination history? Dr. Kannan or Satish, can you please enlighten us about the vaccination history?
Vinod, was he vaccinated for COVID or something?
He has been vaccinated, sir. Fully vaccinated, actually. He has been fully vaccinated for COVID.
Okay. What vaccine? Covishield or
Covishield, I think, sir. Covishield, sir. Not sure about that.
Okay, fine.
So look at the questions about. There is another question by anonymous attendee. How long will you give rituximab for this autoimmune encephalitis? Would you like to answer this question?
Sir, there are only anecdotal reports, sir, and there are a few consensus only, sir, guidelines regarding this. Usually, it says that you can give for 2 or 3 years, sir. Depending on the PET screening, we have to do PET screening for the next 2 years, and depending upon how severe the presentation was, say a patient has status dystonicus or a status epilepticus, we usually give for 2 or 3 years, sir.
To add to the answer of Dr. Nirmal, what we can do is monitor CD19 and CD20. Okay, they activated CD19 and CD20. If they are within range, you don't have to repeat the second dose. You wait. So you keep on monitoring every 3 months the CD19, CD20 count. And if it flares, then you can give the second dose. That can also be one school of thought where they keep monitoring the CD19-20 basis and then give the dose of rituximab. Yes, sir. Anything, sir?
Apart from that, Dr. Lakshmi, I think it may be a good idea to monitor clinical symptoms, because these are the NMDR encephalitis per se is divided into 5 different phases. All of you know that.
Yes,
and so
yes.
sometimes there are late sequelae, and that the secondary psychosis and reactivation of herpes simplex encephalitis also is known with NMDR encephalitis. So these are dreadful complications. Some of them are delayed complications. So this is not as such a single monophasic illness which gets over in a month or 2. Sometimes it is prolonged for many months, and sometimes there are late complications, as I mentioned. Second DIT syndrome, that is what the NMDR encephalitis induced herpes encephalitis. So one has to be very careful, and not only CD19, but we also recommend to look at the clinical pointers, as well as sometimes EEG can also pick up delta brush and so many other things. So I think this is a very interesting case from so many angles. In fact, we could also have discussed NMDR encephalitis and various presentations of that syndrome, but this case itself is a real teaching case, and I appreciate once again. There is third question though: why don't you start him on mycophenolate mofetil or azathioprine, if at all it is started? How long to give in autoimmune encephalitis? So I said there are no such guidelines, but as we mentioned, is all clinical EEG and CD19 related and other immunological markers, of course, and repeat MRI in selected cases where you have new symptomatology. So in general, in our setup, we give for sometime between 6 months to 2 years, depending on the response of the case. Lakshmi, how much you recommend in your patients?
Yes,
How long you recommend?
Yes, sir. Normal. I also follow, sir. Up to 2 years. Up to 2 years, sir.
Yeah, right. Yes. There is another, there are certain, are there any more questions? Yeah.
Sir, actually, with your permission, really it's a very good case, sir. Completely different angle. Yes. And my hearty congratulations to the entire team. Wonderful. I'm sure that the residents would have been benefited. I'm sure that many such patients would be just lying in the ward, labeled as catatonia, and nothing would be done. And this lorazepam test, I don't know whether Nirmal would remember. We had one case post. What happened was, especially post shunt, sir. We live in our institute is both neurology and neurosurgery. One of the complications of shunt migration, what happened was the shunt dysfunction resulted in the hydrocephalus, the dilatation of the aqueduct, which pressed on ventral tegmental raphe, in the midline ventral tegmental raphe.
Okay.
That resulted in a catatonic state, sir. We just gave lorazepam, and the patient was, we went for give an opinion in the neurosurgical ward. Patient was in complete akinetic mute state, catatonic, all vaccine, everything was there. And the moment we gave lorazepam, patient completely recovered in. So the lorazepam challenge test is a very important test which every neurologist specialist should know.
Yes, absolutely. But first of all, one has to recognize and suspect that this is possibly a catatonic state. So
organic catatonic.
Yeah. First of all, the clinical characteristics of the phenomenology, and then whether it is psychological or organic in origin, and all other comorbid condition, as they have described very eloquently, and then treat it. And as the another teaching point in this case was the first MRI was presumably normal, although the quality of the MRI was not so good. And I would have loved to see the first and second EEG also. But having said that, they perseverated and continued and did the second MRI, which picked up. So I think seizure was one of the most important organic finding in this case. So probably that was one of the reasons why they could land up with the final diagnosis from the organic side.
Yes, sir.
And it's good that it's suspected and did an autoimmune encephalitis panel, particularly NMDR and all. So interesting, really. The result of the outcome of the case is excellent. So, but I think we need to monitor this case a little further on.
And Dr. Kumaravel has congratulated the entire team for an excellent case. There are a lot of 2-3 people have congratulated you for an excellent case. The senior people in the neurological fraternity have congratulated you on your excellent case.
Thank you, sir. Thank you.
I think there are some more questions also. Let me check in the box. How much lorazepam we can give before saying it is negative, and how long we should wait to look for the result?
So usually we can start lorazepam starting with a 2 mg. We can go till 12 mg, sir, and we can wait till 1 week to see the response, sir.
Okay.
And the role of rTMS in catatonia.
Sir,
usually in refractory catatonia, the repetitive transmagnetic stimulation is helpful, sir.
So those days ECT was used, sir. Since ECT ECT is cumbersome to the patient, nowadays rTMS has replaced ECT as a secondary line of management in catatonia, sir. After lorazepam, sir. For who have episodic catatonia, rTMS is useful, sir. The target is usually orbitofrontal cortex or dorsolateral prefrontal cortex, sir.
Whether it's a isolated idiopathic NMDR encephalitis or there is some lesion somewhere in the body, particularly as you know in females we have like that. Would you recommend PET scan in such cases?
CT screening of chest and abdomen is normal, sir. PET scan patient was unfortunately not affordable for PET scan, sir. We plan to do it at a later date, sir. Currently, CT chest abdomen screening was negative, sir.
Right.
In fact, one of the question was PET scan finding. Some other doctor, I think Dr. Rupali, Dr. Rupali Mahajan has asked what was the PET scan finding. She was, and then Motir, he said, did this patient need anti-seizure medication? If yes, which one? And how long to continue anti-seizure?
The anti-seizure medications were given, sir. Initially, patient defaulted, but she was on levetiracetam, but we switched to brivaracetam in view of behavioral disturbances. Generally, in case of encephalitis-induced seizures, we usually give for 6 months to 1 year, considering it as a symptomatic seizure. But since epileptic potential of NMDR encephalitis is higher than usual, we usually continue for longer term, sir. We usually require for 1 to 2 years, sir. I don't think there are any guidelines for that, but we usually give for 1 to 2 years, sir. LGI1 encephalitis and NMDA are considered to be high epileptic potential for recurrent seizures. So we usually give for a longer time in these two, especially with comparison to other encephalitis which cause seizures.
Thank you. If there are sir, if no other questions, shall we?
Yeah. Yeah. Somebody has mentioned, Dr. K. Bhanu has written that ECTs are useful and given easily. Any comment on that?
Yes, sir. ECT was ECT is a treatment which was long used in catatonia. It's still useful, sir, especially in patients who are not responding to lorazepam or those who have recurrent episodes for like periodic catatonias. ECT is actually a treatment of choice for refractory catatonias as well. But now RTMS is wherever available, it's replacing ECTs in those scenarios, sir.
Well, I don't know whether in organic keratonias like this, particularly NMD encephalitis, ECT can be really considered as one of the treatment. I am not much in favor of that point. Non-invasive things are probably better. What do you say, Dr. Lakshmi?
Sir, what I realize now is, sir, the future is going to be in the hands of RTMS, sir. Both direct electrical stimulation and RTMS are going to, because I recently saw a case where aphasia for 3 years, following a stroke, post-stroke aphasia, sir, 3 years. And what they have done is one of the peripheries, they have done a fMRI to identify the image guided TMS they have given in both the frontal lobe, both the Broca's they have given, sir.
Yeah. Now that you brought out the point of
sir.
Sorry, yes, go ahead, please. First finish, then I'll ask you something.
No. What is important is I realize that the normal sides, inhibitory action of the normal side, if you are able to curtail that, the neuroplasticity of the lesioned side will definitely improve, sir. So that is what I learned from that case. So my hunch feeling is the future there will be lots and lots of usage of RTMS and the direct electrical stimulation, and that will revolutionize the neuro rehabilitation sectors.
I would like to make two statements here.
Yes, sir.
On the one side, there is a medicinal arm of the treatment of neurological disorders. On the other side, there is surgical arm, including functional neurosurgery. In between now, a lot of space is being occupied by the neurostimulation and neuromodulation. So lots of disorders, right from migraine to epilepsy and disorders like speech, memory, and a lot of things. The stimulation makes even RTMS and RNS response and gamma core and vagus stimulation, and lots of them are going to replace a lot of conventional therapies, either medicinal or surgical, so to say. There is one statement. And in that line, this RTMS may be replacing a lot of things. Only thing, second statement is that RTMS, we have varieties of machines of different calibers and different powers and a lot of things. So perhaps, and as you mentioned, direct current and single, etc., etc. So we need to learn more and more which of these machines are useful for hardcore memory disorders, speech disorders, and then, like you said, aphasia case. Some of them are useful in depression and like catatonia. And so I think the next decade is going to be most exciting as far as the neurostimulation is concerned. This is one side, and on the other side, the deep brain stimulation and techniques like putting chips in the brain. So it is also going to change future of humanity in the coming years. So I'm sure all of us are going to witness a marvelous era of therapeutic advances, at least in neurosciences and neuropsychiatric disorders. Right?
Thank you, sir. Thank you. Thank you.
Yes.
Thank you.
Okay. Once again, thanks to the team for presentation.
Thank you,
Thanks
sir.
to INTAS for the logistic, and thanks to all the delegates. And thank you once again. Stay well, stay safe, and enjoy your life with full happiness. We meet next month and we declare the time and date in some coming time. Thank you very much.
Thank you so much, sir.
Thank you, Arvind. Dr. Lakshmi, you want to close?
Thank you.
Okay.
Thank you.
Mr.
Thank you,
Chadda,
sir.
please.
And
Over to
today we are incredibly grateful to all of you for joining us in the Secret of Neurology. And we have successfully completed the 52nd session of this insightful web series. On behalf of Intas Pharmaceutical, I, Arun Chadda, Vice President of Intas Pharmaceutical, extend the heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 52 months. A special thanks goes to our esteemed course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which got lot of love and the affection from all the DM and DNB students, those who are joining every month regularly from the last 52 sessions. And this program will undoubtedly a valuable resource for all the DM and DNB students. We are incredibly grateful to the young neurologist Dr. Monica Reddy for sharing their insightful case presentation. And we are thankful to Dr. Satish Kumar for localization this case. And we are thankful to Dr. Nirmal Kumar for giving insight of this case. Our deepest gratitude goes to Dr. Vasudevan sir, HOD of Sweta Medical College, Chennai. Unfortunately, he is unable to attend this session. In place of him, he has sent Dr. Vinod Kanan for giving the final discussion. So we are very thankful and grateful to Dr. Vinod Kanan for giving the final discussion and provide the crucial learning points and the summarizing the proceeding of unique presentation. Once again, a heartfelt thank you to all of you for your gracious presence. It has been a true pleasure being with you today. And at 53rd session of Secret of Neurology, we will meet again on December 27th, or if there will be any change in time and date, so we will inform you by email or by SMS. Until then, stay safe, take care. Thank you to all of you. Thank you very much. Thank you, sir. Thank you very much.
Shraddha